So, welcome to you all. My name is Catherine van Montfrans. People call me Bibi. I'm a dermatologist working in Rotterdam, the Netherlands. And today we will have a webinar on a phlebological topic. And we chose for you hypertensive leg ulcers and punch grafts. And I'm really happy that we have two guests today. Next slide, please. And our guests are Elena Conde Montero from Madrid and Jürg Hafner. And Elena, maybe could you introduce yourself?
Thank you, Vivi. I work in Madrid in a public hospital. My main interest is leg ulcers.
Perfect. And Jürg, what about you?
I work at the University Hospital of Zurich, Department of Dermatology, and I run the division of inpatients, of dermatologic surgery, skin cancer, and also of wounds and phlebology.
Yeah, and so we met at the EADV Congress, the three of us, and we also visited Elena's hospital. And Jürg, in fact, is for Elena and me our big, well, let's say, mentor in leg ulcers. Yeah, I'm sorry. And how to recognize Marterell's leg ulcers. And Elena, in fact, is the one who really put back into practice the placement of punch grafts. So we will tell you all about this this afternoon. Next slide, please. So why are dermatologists involved in phlebology, and why should we be involved? Well, I think we, as no one else, can recognize clinical signs of phlebological disease, and we can distinguish it from other skin diseases. We can do the investigation ourselves, except for inspecting the legs. Also perform a duplex ultrasound, and then make a good diagnosis and a treatment plan, and also evaluate the benefit of our treatments. Next slide, please. So our first topic today is how to recognize hypertensive ischemic leg ulcers. And I would like to give the word over to Jürg to tell us a little bit more about this. And if you have any questions, please ask them in the chat. We will have a lot of time to answer all your questions. And we hope that after this webinar, you will be really able to recognize hypertensive leg ulcers and distinguish them from other type of ulcers. And tomorrow be able to start placing punch grafts for these patients. So, Jürg.
Thank you, Bibi. Hypertensive ischemic leg ulcers, as they have been described by Martorell in Barcelona in 1945, are quite frequent. In our population, they make 10% of all leg ulcer patients. It is probably an under-recognized disease, except for France and for Spain, where physicians are aware of this entity. You will encounter a patient who is typically 60 years old or older, and the patient presents with a very painful necrotic area at the laterodorsal aspect of the calf. This is very typical of the leg. Sometimes also over the Achilles tendon. The ulcer is progressive, and the border of the ulcer is violaceous. It is like livido. This is why it is sometimes confounded with pyoderma gangrenosum, or also with vasculitic leg ulcers. And as a matter of fact, on purely clinical grounds, you cannot 100% certainly distinguish the three: Martorell, hypertensive ischemic leg ulcer, pyoderma gangrenosum, and vasculitic leg ulcers. So it is the whole pattern, the age of the patient, the typical location, which is very characteristic, and other elements that tell you if it is rather Martorell or the other differential diagnosis. Next slide, please. These are other examples of Martorell. You see the progressive infarction, the skin infarction. On the left-hand side, you have a slide where you see an ulcer that is progressive. In the proximal area, you see this violaceous black border. This is also why physicians who are unaware of the disease tend to diagnose pyoderma gangrenosum. On the right-hand side, you see another example where it is not on the laterodorsal, but on the anterior lateral aspect of the leg. So this is not pathognomonic, but very often it is on the laterodorsal aspect of the leg. We do not know yet exactly why this location is so often there. Next slide, please. Here you see more examples, also starting Martorell pathologies where you only have this livido racemosa, which does not change with temperature or with time. It's always there. And you see on the left-hand side, almost in the middle, this ulceration over the Achilles tendon. This is very typical also for Martorell. It's not so well known. Next slide, please. So on blood examination, you should do a workup also for renal insufficiency. That includes calcium status, vitamin D, parathyroid hormone, phosphate. And there is some discussion in the literature if you should always do a biopsy or only in severe cases. In French literature, physicians are reluctant to do wound biopsies, but we will show you how we do them in case we decide for a wound biopsy. French physicians tend to say that if the clinical pattern is almost certain, you can avoid wound biopsy because they fear iatrogenic damage to the patient through the wound biopsy. This is something we do not fear so much, but I have a lot of understanding for that point. Next slide, please. So you see now on the left-hand side a typical Martorell ulcer with the skin infarction on the laterodorsal aspect of the leg. And on the right side, you see pyoderma gangrenosum. This is a slide that was given by Bibi. In pyoderma gangrenosum, you typically find a more superficial necrosis. And it is like if the skin would become liquefied. I have other examples where you can find that more typically. Here you see now how we do the wedge-shaped spindle biopsy that starts from the healthy skin in the surrounding area and goes to the wound bed. And then this is shown in the next slide, please. We transect this spindle in the longitudinal way, as we do not transect it like it was a baguette from Paris in many transversal sections. We do not make slices of bread, but we transect it in a longitudinal way, because like this, we get like a profile that starts from the border and ends in the wound. And then when you embed this into formalin, paraffin, and do the stainings, just hemalaun and eosine, you will find the pathologic arterioles. Next slide, please. And here you see the distinction between pyoderma gangrenosum and Martorell hypertensive ischemic leg ulcer on the left side and PG on the right side. So you shouldn't do punch biopsies from these wounds because in the superficial layers you won't see any difference. You always will find necrosis and dense sheets of neutrophils. So you may misdiagnose hypertensive ulcer as PG if you only take a superficial biopsy. But when you take these deep spindle-shaped biopsies, you are able to find the arterioles that are so characteristic with the thickened wall and very often with the medial calcinosis of the arteriolar wall, which is only present in hypertensive ulcer but not in pyoderma gangrenosum. Next slide, please. So if you find an elderly patient with a painful necrotic ulcer on the laterodorsal aspect of the leg or over the Achilles tendon, the person is hypertensive, mostly since many years. Hypertension is under control. This is why the person has not hypertensive cardiopathy, has not myocardial infarction, has not stroke, but has exclusively hypertensive leg ulcer. Then you should think of Martorell hypertensive ischemic leg ulcer. It looks like pyoderma gangrenosum, but it is not. And treatment is totally different. These persons need surgical treatment and no immunosuppression. Now my colleagues will go on with the presentation and explain you why it is so important to make a clear distinction between the two entities, because treatment is very different. Next slide, please.
Thank you so much, Jürg. I wonder if there's any question from the audience, or Elena, maybe you want to ask something to Jürg?
Yeah, I would like to ask something to Jürg. Well, first of all, I'd like to say that everything I know about Martorell leg ulcers is thanks to you, Jürg. And now the question. So traditionally, Martorell ulcers have been associated to very bad control hypertension. So in your practice, do you find more well-controlled blood pressure patients or badly controlled? Which is your experience?
Virtually all patients have well-controlled hypertension since decades. This has changed historically since the first description in the 1940s. In the 1940s, physicians were not able to control high blood pressure, and the first prototype patients were described as an area where medicine was not able to control hypertension. Meanwhile, in many countries, all persons with hypertension are under good control. This is why we don't see so much anymore stroke and myocardial infarction. So these cardiovascular diseases are much better under control than 20, 30, or 40 years ago. However, we see more and more patients with a late complication of hypertension, that is Martorell hypertensive ischemic leg ulcer. And all our patients are actually under good hypertensive control.
Thank you, Jürg.
So I see a question for you, Jürg, in the chat, and the question is, instead of taking one large incisional biopsy of around 4 or 5 centimeters, is it also possible to take multiple mapping biopsies to make the diagnosis Martorell's ulcer, or to exclude, for example, vasculitis, pyoderma, or maybe a malignancy?
Mapping biopsies are adequate to exclude malignancy. However, since these arterioles are not spread very densely at the border of the dermis and subcutis, you find them every some millimeters, but not every millimeter. You have a high risk of getting a sampling error when you do mapping biopsies with small biopsies, and you may biopsy next to an arteriole instead of into the arteriole. This is why you have a higher chance to find the pathologic arterioles when you do a long transection through the skin in the longitudinal way, very narrow, because then you can stitch it together again, and you have a lower risk to miss the pathologic arterioles. Also, when you are looking for vasculitis, by the way, we always use the tip of the spindle, there where you have the healthy skin, to provide direct immunofluorescence to be even more sure that we do not deal with vasculitis. This was something I missed to say before.
Okay. And then another question. So what about the prognosis of these patients? Is there a high mortality? Because there might be sometimes a confusion if this is called a calciphylaxis cutis or a hypertensive ulcer of Martorell. And calciphylaxis is associated with a really high mortality. Can you say something about the prognosis and the how to distinguish it from calciphylaxis?
Calciphylaxis is closely related to Martorell hypertensive ischemic leg ulcer. We wrote an article on that because it's quite a complicated issue in dermatology in 2016. This would summarize my answer. Since the moment that we recognize earlier Martorell disease and we stop immunosuppression in those patients who are referred under immunosuppression, and we start surgical therapy under antibiotic protection, we do not lose any patients anymore. In earlier times, we saw patients with Martorell ulcer die from sepsis when they were under unnecessary immunosuppression. But the prognosis of Martorell hypertensive ischemic leg ulcer is much better than that of calciphylaxis. Calciphylaxis is only applied in patients who have kidney disease.
Okay, clear. So Jürg, there's a question from the audience, and that is, does obesity worsen the Martorell ulcers?
This is an interesting question. Thank you. There is a kind of central Martorell disease or proximal Martorell disease. That means that patients who show morbid obesity can develop this type of skin necrosis at the abdominal apron, that is at the abdominal fold, at the inner side of the thighs, at the upper arms. Females can develop this type of skin necrosis also at the female breast. So this looks like the central type of calciphylaxis in end-stage kidney disease. But these obese patients do not have kidney disease. So they call that calciphylaxis in the absence of kidney disease and in the absence of parathyroid disease. So in these patients, indeed, obesity worsens the prognosis. However, if patients show with classical peripheral Martorell disease at the lateral dorsal aspect of the leg, we do not believe that obesity in itself worsens the prognosis. Only in those patients with a kind of proximal Martorell disease, so those who have calciphylaxis in the absence of kidney disease, which is also a kind of Martorell, and these patients have always morbid obesity. There, the prognosis is not so good.
Okay. And so another question from the audience by Mosmo is as follows. Is there any role for ultrasound in a diagnosis to see the pathological arterioles instead of surgical biopsies?
I cannot answer that question. I do not believe that you can see these arterioles in ultrasound because they are at the depth of approximately 0.8 to 1.5 centimeters. So you would need high-resolution ultrasound to find these fine structures. And high-resolution ultrasound penetrates only 1 to 2 millimeters into the skin. So I believe physically it is not possible to depict these arterioles with ultrasound because they are too deep and they are fine structures. But maybe I am wrong. I cannot really give the answer. But there are some papers that have been done. We are unfortunately not able to do that here at the University Hospital. Those scientists or clinician scientists took the same technique of radiographs as you use in mammography. So that means you take very weak tensions, very weak kilovoltage to do the radiographs, as in mammography. So when you use the mammography technique and you do radiographs of such a leg, you will find the pathologic arterioles in the subcutis, but not when you do a conventional radiograph as to find a calf fracture or something like this, a leg fracture. So when you take 150 kilovolt radiograms, you can't find the arterioles. When you take 30 kilovolt radiographs, as you use them in mammography, classical mammography with X beams, you can find the arterioles. But this is something, unfortunately, our radiologists at the University Hospital of Zurich do not offer.
Yeah. Oh, that's so interesting. I didn't know this, Jürg. So we learned something new as well. So if there at this moment are no more questions from the audience, then I just suggest we should continue with our presentation. And now Elena and I are going to tell you about how we do the punch graft placement. Next slide. Because ulcers of Martorell, they really respond well to either split skin grafting or punch graft placement. And this is in contrast, for example, to pyoderma gangrenosum. And the punch grafts can be placed also if there's still necrosis, if a plastic surgeon would never think of doing anything. He wants to clean first the ulcer. But Elena has discovered if you, for example, in the center, you have a clean center and you put your punch grafts there, then they I think we think they excrete all kinds of anti-inflammatory cytokines and proteins, and it has an anti-inflammatory effect. So what do we do? Well, it's really easy. We do it in an ambulatory setting, and this is what we all prepare. Next slide, please. And I have a short movie here, just of the anesthesia of the donor side. Maybe Ricardo, you can play the movie, if it's possible. Yeah. And so you see if you can go back, yeah, for a second. Yeah, we just do punch graft placement in series. So we do it a first time and then we do it maybe a second time. So this is the second time we do it in this patient, and then we just anesthetize locally, maybe with 1 or 2 injections. Okay, and then we are not really using the punch biopsies anymore, but we do something different and much easier. Yeah, so we can go to the next slide. We just cut them loose with a knife, and then we place them on the ulcer. Ricardo, I think we have a movie here too. Let's see if we can. Yeah, so this is how we collect the punches, just with a knife. You can take number 15 or 11, and this is a little bit slow motion. Well, in fact, we don't do it in a sterile setting. I'm not sure. Well, we disinfect it, of course, but I'm not sure how you do it, Elena. If you use sterile gloves and a sterile setting, but well, you don't.
We don't.
Not anymore.
No.
So this is just and so we do it really superficially. So if we see the bleeding, we don't want to see too much bleeding. And you can also see that the punches. This was maybe 4 weeks ago. The previous punches, that they heal really quickly and nicely. If we go to the next slide, Ricardo. And this is a movie too, I assume. If we can play it, let's see. We place them, and you just have to take care what is the upper side and the lower. Yeah, the side that should be attached to the skin, and this is something I just place them, like that. Elena, if you have any comments, just tell me.
It's perfect.
Yeah. Okay. So, and then this is how we place them. And I mean, here I am doing it with a colleague, but Elena will just tell you in a second that also her nurses can do it. And it depends a little bit on the situation in your hospital, if your nurses are, let's say, allowed to do this, and if they want it. Okay, next slide, please. Yeah, and so that's how we do it. And then maybe, Elena, you can tell a little bit about the situation in your practice.
Yeah, I'm going to talk about what we do in our clinic. So it's a procedure similar to what Bibi has just explained. But well, here you can see the material there is low-tech material, as you can see. And Bibi talked about this bleeding. It has to be a point-sized, just to be sure that you are in the dermopapilla, in the union between the epidermis and between the papillary dermis and the reticular dermis, and you have point-sized bleeding. And well, some of you will ask, which dressing do you use in the donor side? So there you can see the dressing we use, calcium alginate. We adore it because of its hemostatic effect. But you could also use other dressings. No dressing is superior to others, but the first 2-3 days, we really like alginate because of the hemostatic effect, as I said. So we have to put pressure on the donor side just to avoid bleeding. So we will go to the next slide. And you can see that we use a surgical blade, a scalpel, directly. We started marking the grafts with the punch, but now we just do it like that, and it's very quick. And if you are 2 people doing it, one is taking the grafts and the other one is placing them. So it's very quick. It's very quick. You just have to change tweezers, and we don't even have to gather all the grafts and put them afterwards. We can do it at the same time. So when you are 2, it's very useful. And sometimes we are 3 because we have lots of ulcers or very big ulcers to graft. So when you work as a team, things go faster. And we can go to the next one. Yeah.
Elena, I have a question. So, is there what is the size? Is there a size limit to the ulcers that you treat with your punches? I mean, should they be small or?
Well, in our clinics, as you know, we don't have a limit. This is a very interesting question. Obviously, if you have a very big ulcer, you can take a split thickness graft, a mesh graft, and this is quicker. But in fact, as this procedure, we do it in an outpatient basis, and we are a big team. It's very, we can graft a whole leg with this and no problem because we work as a team. But if you have a very big wound, a mesh graft will be faster, obviously.
And if you have the Achilles tendon, if you see it, what do you do then?
Okay, you have 2 options. If you have a surgeon or if the tendon, the denaturalized part can be taken away, you can take it away surgically. But if not, what we do is we put, and if you have an old patient and the tendon is not destroyed, what you can do, and if no surgeon is going to do anything there, you just can put the grafts around the tendon and on the tendon too, over the tendon, because the grafts will protect the tendon that's viable, and the grafts in the edges of the tendon will promote epithelialization from the edges. So obviously, parts of the tendon will go away, but we will preserve a big percentage of the tendon, and we will achieve wound contraction. This is, I don't know which is your experience, but we do it very often.
Jürg, what about you?
Sometimes it works. I agree with Elena. Elena is an absolute pioneer in punch grafting, and I also tried when she told me, and it works. Sometimes it works, not always. Sometimes you have to let the surgeons resect the tendons. Sometimes it's the peroneus or fibular tendon. Sometimes it's the Achilles tendon. Elderly patients can walk normally without Achilles tendon. This is surprising. So if nothing heals anymore and the tendon becomes dry or even black, there's no use anymore to try grafting. But as long as it's a fresh wound, the tendon is exposed, but it looks vital, you should try punch grafts. I absolutely agree with Elena, and you may be able to save the tendon. Absolutely.
Okay. Yeah. Okay, Elena.
And now, well, I wanted to show you how the donor site evolves during time. So, first slide, first picture. This is the day you perform the procedure. 15 days later, 3 months later, and the last one, the fourth one, is 6 months later. So you can have hypo or hyperpigmentation, but the result is normally quite good. You have to take care with phototype, with high phototypes, but the point is that for the patient, this is not a problem. And in the next slide, we will see something that can occur when we've seen these reactions, this inflammation in the donor site, mostly when we leave the dressing, the primary dressing, for a week, for instance, when this donor site has suffered lots of bleeding. This is not unusual, but what we try to do to avoid it is to reduce reduce the time between dressing changes. So we just leave the alginate there for 3 or 4 days and we change it. And this will reduce the possibility of the happening of this complication. But it will be healed with topical corticosteroids, so no problem at all. We will put it, just imagine these two pictures, 1 week after the procedure. You just have to put some local corticosteroids. We put alginate on it, and in 1 week, changing the alginate and corticosteroids, this is healed. But this can occur. This is not infection. On the next one. The other question that you would like to ask is, which dressing do you use as a primary dressing? So, once again, as in the donor side, we don't have the best dressing for the grafted wound, but you can use interface dressings, such as this one here, and afterwards alginate or other dressings are as secondary dressings. But I have to tell you that sometimes, several times, we use directly alginate on the grafts. So some of you can think, but this dressing may adhere to the grafts. I'm not sure. I would prefer an interface. But the fact is that those grafts, we try to make the first dressing change the later as possible. If we can wait 1 week, we won't change it 3 days after the procedure, obviously. So those grafts that have taken won't adhere to the alginate. And if you put lots of water there, you will take the alginate away without problem. And you can re-put the grafts. Just imagine some grafts, you take them away from the wound. You can put them once again and take them from the alginate. So there are several possibilities. Interfaces are very used, but from time to time, we just use alginate on them. I don't know, Bibi and Jürg, which is your experience? This is my opinion.
Well, we started with putting an interface like a silicone dressing, but then often we saw it was like too macerated, too much liquid. So now we put the alginate directly on the grafts. But just the other day we changed the dressing after 4 days because they were all like, it was all green exudate, and then with the dressing came a lot of punches, so I was really unhappy. And also this patient had a lot of pain after the placement of the punches, which is very unusual because often the pain, that is one of the advantages, within hours it is reduced enormously. So only for the pain reduction, the placement of the punches is an enormous good treatment. So this was like not such a good outcome, but I didn't think of putting back the punches on the leg again. I should have spoken to you.
We do it very often. Well, we do it every day like that, yeah. And it's not a problem if you have to regraft them. I don't know, which is your experience with the primary dressing? Yeah.
One interface with a fatty gauze and an alginate on top.
And as you can see in this picture, we put zinc oxide on the edges and perilesional skin to protect the skin, because after grafting the wound, you can have more exudate because of neoangiogenesis and so on. So we do it very often, yeah, to prevent population too.
And so what do you advise, Elena, to the patients after placement of the punches? I mean, should they stay in their beds or can they move?
Immobilization is essential after placing the graft. Local pressure is essential too. We normally put bandages adapted, then the compression will be adapted to the patient and the patient situation, vascular situation, and the patient tolerance. And immobilization, it's essential. The first 3 days are very important to promote graft taken, the attachment of the graft, neoangiogenesis. But the first 5 days, and if they come 7 days, it will be perfect. And those patients that cannot rest that time, we just they will become inpatients, even if the procedure is outpatient procedure. But those patients that cannot rest at home, they should be rest at the hospital. So it's very important to immobilize. If not, punch grafting will not, graft taking won't take place.
And do you use like a immobilization? I don't know how to call it. It's
a cast.
Like a cast. Yes, exactly. A cast. That's what we give them, so that they cannot move their ankle joints. In addition to the compression, we do that.
Okay, we just used a cast in the Achilles tendon area for some patients, but in the rest we just put bandages with compression adapted to the patient.
And you, Jürg?
I agree with the last 2 sentences of Elena.
Okay. Okay, not always a cast. Okay.
No, rarely.
Rarely. Okay. Okay. So did you have any more slides, Elena, that you wanted to share?
I just wanted to show you 2 cases, just for you to see how is the evolution. Next slide. Because this is the main pearl of punch grafting. You don't have to touch anything. That means cleansing should be slight during dressing changes, because even if no single graft has attached to the wound, those grafts will release cells and interesting growth factors for healing promotion. So it's very important not to cleanse the wound, even if you want to do it. So we'll see some examples. Next one. So for instance, this is the typical martyral leg ulcer, very painful. Now, next slide. What we will do, we will put the grafts in there. Some people would say, I would prefer to do some debridement. Okay, the patient it has 1,000 has pain. 1,000 to 10 is just terrible. She won't be able to go through debridement, and so we just put the grafts there. And next slide. This is the evolution 2 weeks after the procedure. We made 2 dressing changes. This is the second dressing change. And as you can see, we have some areas without graft taken, but no problem at all. We just wait 1 more week, and we will just have 1 area to regraft. We will regraft this wound, and next slide. We have complete epithelialization in 6 weeks, and this patient had been suffering with this wound for 5 months. And the most interesting thing is that from day 1, pain will decrease. As Jürg Hafner says, grafts are the best painkiller for martyral leg ulcer, and they are in fact. And we will go through the next case. another martyr leg ulcer. So what will we do? We will put grafts on it. So we put the grafts and the patient comes 1 week later. So here is the situation. Next slide. We see this saturated yellowish grafts. So if you do not know the technique, what will you do? You will just cleanse everything and okay, no way. But the patient says, I have 0 pain, 0. And as I've said you, the most important thing is not to touch anything. So we just put the dressings on and the patient comes the next week. So this is what we find there. Next slide. Okay, punches are there, yellowish, whitish, some grafts. What we do, we don't touch anything. But now you will see the next slide. Here is we can wait with these terrible grafts for 3 weeks. When you cannot get more from these yellowish, whitish grafts, you just say, okay, I can regraft. And this is what we did, what we found after regrafting the wound. So you can have next slide. And this is 5 weeks after the first procedure. So we waited 3 weeks with these terrible grafts, but they were releasing growth factors, cells, interesting cells. We had to regraft a small wound, but without pain from the first day. And in some weeks, you have complete healing. So it's important to know that obviously, if you graft a perfect wound, in the following 2 weeks, this wound will have complete epithelialization. But if we graft terrible wound beds, you have to expect that those grafts will have a terrible appearance. So you have to be patient. That's it.
Yeah, perfect, Elena. So we have a question from the audience, from Babette de Waard, and she asks, does anyone has experience with epidermal skin graft, the cellulome, by this kind of ulcer? Should that be an option?
Okay, I have experience with cellulome, but not in this kind of ulcer. And I will give you my opinion. Cellulome will act, the grafts taken with cellulome will act as those grafts that do not adhere to the wound, because these keratinocytes will release growth factors, but you won't have graft taken. So, in my opinion, even if the studies you find that they show good results, I think that for our patients, it's not a problem to have a scar at the donor side, and cellulome has costs, and you have to spend time with it. And I don't think that if we can have grafts taken with the epidermal graft, why will we go just with epidermal grafts that will just provide cells and growth factors instead of complete neoangiogenesis? And the neoangiogenesis process, when grafts take, I don't know, because I cannot tell you the exact biochemical process, but in fact, I'm sure that this neoangiogenesis has an important role reducing the necrotic and pro-inflammatory environment of the wound. So this is my opinion. Now, Bibi and Jürg, you will tell yours, but if we have this very simple technique, I think it's more interesting to go with it rather than just epidermis. I don't know which is your opinion.
No, Elena, I think I agree. So we have another question from the audience, and that is in Zurich, Jürg, do you have another opinion about the immobilization after grafting? Do you do it for 3 to... You don't immobilize, eh? Not at all.
No.
Oh, okay.
Now, this is very interesting, because we just think that when grafts do not adhere, when we do not succeed, we think this is because of immobilization. The patient has not. Okay, so this is interesting to know. We just associate when we don't have success, we just think it's because of that. So interesting.
It's very interesting because we also give them anticoagulants because we immobilize them, and so that it can also lead to more complication. It is also difficult for them to immobilize. So maybe Elena, we can try without immobilization. So thank you for this question, Ibrahim Al Sulaiman. Okay, so there's another question. Maybe we can ask Jürg. Do you see any new ulcers or coming?
No.
Do the ulcers come back?
No. In half of patients, you will see martorell ulcer on the other side. Sometimes simultaneously, so you will have on the right and on the left leg, on the lateral dorsal aspect, martorell ulcer at the same phase. But more often, you get to know a patient in the year X, and 2 years later, you will see the same patient for the other leg. But once the process is healed, you won't have recurrence.
Okay, that's also really interesting. Good to tell your patients that it has a good prognosis after the procedure. So there's another question from Eyas Khan. So is there what are the criteria for to select an ulcer for this procedure? So is it maybe only Martorell's ulcers, or can you graft also other ulcers? Elena, maybe you can answer.
Well, you are asking me, Bibi, that I graft any ulcers. I graft everything. So first of all, you have to have a clear diagnosis of the ulcer you have. Obviously, you won't graft a malignant ulcer. You won't graft an arterial ulcer that obviously, first of all, will benefit from revascularization. So first of all, you have to do the etiological treatment of the ulcer. And once the cause has been treated, you can use this procedure to promote epithelialization of any wound, once again, when the cause of the wound has been treated. It's nonsense grafting a venous leg ulcer without compression or without an endovenous treatment if the patient will benefit from it. So first of all, you will treat the cause, and afterwards you will help with this procedure.
And so also pyoderma gangrenosum patients?
Once inflammation in pyoderma gangrenosum is controlled, you can graft those patients. Once the cause of the wound has been controlled, and it's not that easy in pyoderma, but we've just published a case in our clinics in a young woman, because the problem with pyoderma is that when inflammation has ended, but the wound is so big, and so it's, people say, oh, pyoderma is refractory to treatment. It's very difficult to heal. But the problem is that the hole that inflammation has left. So when inflammation is controlled, you can use negative pressure, you can use grafts to promote healing.
Okay, so there was another question from a participant asking, can you use grafts for venous ulcer? And I think your answer is yes, sure you can.
Yes.
Yeah, okay. So I have one last question, maybe. Do you use antibiotics peri-procedural, Elena?
I don't use them, and no, I don't use them.
And you, what about you, Jürg?
In large cases where you have considerable infection, I use antibiotics, but not on a regular basis, not every time. I reserve antibiotics for situations where you really have relevant contamination or infection.
Okay, and I see another question here from Dr. Zakosa. Elena, do you graft also diabetic ulcers?
Once the ulcer has been treated by or has been assessed by the vascular surgeon, the podiatrist, and you have the offloading of the lesion to promote epithelialization, you could use it. But once again, after treating the etiology of the wound. But yes, we've grafted some of them to promote epithelialization. And I have some podiatrists, some friends of mine, podiatrists, that they have good results. So it's good, yeah.
Perfect. And do you also treat two legs at the same time?
Yes. In fact, as we immobilize in our clinics, patients have to be immobilized. I don't know if tomorrow they will, but until now we had to. So if they have several wounds, it's very easy to immobilize both of them. Yeah, we just take advantage of the. Yeah, and now we have this slide there. Obviously, split skin grafts are interesting for larger wounds, but in our clinics, for instance, this wound here, we could graft it. Yeah.
Exactly. Because with split skin grafts, people are often admitted to the hospital and they get anesthesia, total anesthesia or blocks. But people stand up from and walk out of our room, so the punch grafting is much easier, much less downtime. So I guess we are now at the end of our webinar. Thank you so much to all the participants for all your interesting questions. It was a pleasure to answer them. And I was happy also to have this nice talk with my dear colleagues Elena and Jürg. So in summary, you are all now able to diagnose hypertensive ischemic leg ulcers of Martorell. And tomorrow, I hope you're all starting to apply punch grafting. We are preparing an e-learning with all the movies that we showed today to you and all the different steps you have to take, also containing a PowerPoint presentation that you can show to your colleagues and your nurses to really start doing this procedure, which is really cost effective and easy to apply, and you will have happy patients. So thank you for all your compliments to all the people that listened. I wish you all a good afternoon. And thanks so much to the EADV staff, to Ricardo Leijten, who made this all possible. So good afternoon.